Well, Ngungri Nungi, everyone. G'day from Ngunnawal country. It's wonderful to welcome you here to the next in our series of Riverland Academy of Clinical Excellence Grand Rounds, and an opportunity for the members of our academy to hear from experts from around the world, to interact with the research, inform our practice, and form better research collaborations as a result. Today, we are very fortunate to have a South Australian collaborator that we can hear from. As part of RACE, you would be aware that we are working with the importance of healthy fats in diabetes remission. But could it be that healthy fats and oils are also important at other crucial times in people's lives? Well, we've got a research team that is world-renowned in this regard, and we've got the opportunity to hear from them today. Dr. Karen Best, an academic midwife and the leader of the team at SAHMRI in Adelaide, has joined us, and we are very fortunate to hear from you, Karen. Thank you for joining us, and we look forward to what you have to say, and then the opportunity to ask and get some answers to questions after that. So thank you. Over to you, Karen.
I'll do my best. Thank you. Thanks for having me and for the introduction. I will share my slides. Is that all good?
Perfect.
All right, great. So, today I'd like to share with you a little bit about the work we're doing in omega-3 fatty acids in preventing preterm birth. So, a little bit of background to start with. All right. So we know that preterm birth is classed as birth before 37 weeks gestation, and early preterm birth is birth that occurs before 34 weeks of gestation. Worldwide, 15 million babies are born preterm every year, and around 26,000 of these are born preterm in Australia. Preterm birth is the single greatest cause of death and disability in children under 5 years in the developed world. And we also know that Aboriginal mothers have double the risk of preterm birth to non-Aboriginal mothers. We also know that around 75% of preterm births occur spontaneously, and there are few treatments for prevention. One of the few interventions that has shown some promise is omega-3 long-chain polyunsaturated fatty acids, in particular docosahexaenoic acid, or DHA, and eicosapentaenoic acid, or EPA. These fats are both found in fish and in fish oils, and there's evidence, a lot of evidence actually, many years of investigation have shown that these fats can actually extend the length of pregnancy and therefore reduce prematurity. So the SAHMRI Women and Kids team have actually contributed to a fair bit of the evidence that there is around omega-3 fats in pregnancy. In 2018, we published the Cochrane Review of Omega-3 in Pregnancy to Reduce Preterm Birth. And this was a large review. It included almost 20,000 women from around 70 countries. And what we found was that taking omega-3 supplements reduced the risk of having a baby or having a preterm baby less than 37 weeks by 11%, and it reduced the risk of having an early preterm birth by 42%. So as well as the Cochrane Review, our team was also conducted the largest trial of prenatal omega-3 to reduce the incidence of preterm birth, or the ORIP trial. We conducted this trial in 2013 to 2017. It was a national trial that included 6 centres around Australia, and we managed to randomise over 5,500 women. It was a double-blind randomised control trial. The intervention was either fish oil, of around 900 milligrams of both DHA and EPA, and the control was vegetable oil. And women were asked to take these supplements from enrolment, which was less than 20 weeks gestation, until they were 34 weeks gestation. So our primary outcome was looking at early preterm birth, less than 34 weeks gestation. One of the benefits of the ORIC trial is that we had blood samples at trial entry, which is how we sort of differed from a lot of the earlier trials. So that meant that we could actually assess maternal omega-3 status in early pregnancy prior to any supplementation. So interestingly, the overall results of the ORIC trial showed no overall effect. It was a null finding, which we were quite crushed about initially, as you can imagine, after such a large trial. But in saying that, the women that were involved, there was a lot of women who were already taking low-dose omega-3 supplements before they joined the trial, so they were actually already replete in omega-3. And the secondary analysis that we did in 2020, where we included over 5,000 singleton pregnancies, this is where we delved a bit deeper and found out exactly what was going on. And we saw that the benefit of omega-3 in reducing the risk of preterm birth was actually limited to women with low omega-3 status at study entry. And in those women who were supplemented with omega-3, there was a 77% reduction in early preterm birth in those women. However, conversely, we also found that women who entered the trial with a high baseline omega-3 status and then also took high-dose omega-3 supplements, this actually also had the potential to increase their risk of early preterm birth as well. So there's like a Goldilocks effect where you sort of need the right amount. Our ORIC results were backed up by another large randomized trial from the US, the ADORE trial by Susan Carlson, and they also showed that women with low omega-3 status were likely to benefit most from supplementation. So it became clear to us that a precision approach may be needed. And women with low omega-3 status in early pregnancy are at higher risk of preterm birth, and omega-3 reduces this risk for them. Women with sufficient omega-3 status are already at low risk of preterm birth, and they don't need extra omega-3 supplementation. So the ORIC trial showed us that the benefits for preventing preterm birth might be best achieved through a targeted supplementation strategy rather than a one-size-fits-all approach. So based on emerging evidence, the NH and MRC pregnancy care guidelines were updated to include advice for pregnant women to supplement with omega-3 long-chain polyunsaturated fatty acids, and that this, if they were low in omega-3, and this may reduce their risk of preterm birth. But the problem there lies, how do we know who is low in omega-3 and who needs to supplement? So in response to the new evidence-based recommendations, we partnered with SA Pathology to implement and evaluate a statewide omega-3 test and treat program to prevent preterm birth in South Australia. The aims of the omega-3 test and treat program are to firstly incorporate an omega-3 test into routine antenatal care, so then we can identify which women have low omega-3 levels. And then based on those findings, we can provide evidence-based recommendations about supplementation to women based on their result. And finally, we will evaluate whether our program is successful by using de-identified data linkage with pregnancy outcomes from the Pregnancy Outcome Unit, and have a look at preterm birth rates before our program started, and then throughout the program, and hopefully we'll see reductions in preterm birth in South Australia. So we needed to, if we were going to embed something in, current practice in antenatal care, we needed to make this as simple as possible for practitioners. So with our partnership with SA Pathology, we were able to add an omega-3 checkbox to the SA Pathology SAMSES form. So this meant there's no additional blood test for women, and that the omega-3 test can be ordered for any women with a singleton pregnancy that's less than 20 weeks gestation as part of the SAMSES referral. So health providers can simply either tick the omega-3 box, or, as we know, a number of women are opting not to have SAMSES and have private testing. These women can still be tested by either only ticking the omega-3 box on the SAMSES form or writing omega-3 to SAMSES on any standard pathology form. We've also designed these forms, the SAMSES forms, in a number of different medical practice software so that they can be ordered electronically. So once the omega-3, the blood goes to the omega-3 lab in SAHMRI and gets tested for omega-3, results are returned back to SA Pathology for reporting to the healthcare provider along the usual channels. Along with the report of the omega-3 status result, there's also included there supplement advice based on what the woman's omega-3 status is. So the women we're trying to target are those women who are low and less than 3.7% omega-3 in serum. And the advice for those women is to take omega-3 fatty acid supplements until their 37 weeks gestation to reduce their risk of early preterm birth. And we do offer a suggested dose there of 800 milligrams of DHA and 100 milligrams of EPA. And this is what we used in the ORIC trial. We do have a list of supplements on the website that contain similar amounts so that women can access, they can choose which ones they might like to take. Women in the moderate range between 3.7 and 4.3% don't need any action because they already have enough omega-3. If they're already taking an omega-3 supplement as part of a multivitamin or a standalone supplement, then that's fine and they can continue. There's really no action for those women. Women who are sufficient or above 4.3, in these women, they're at low risk of preterm birth based on their omega-3 status anyway. So they actually don't need omega-3 supplements. They're not going to provide any additional benefit to their reducing their risk of early preterm birth. So we do advise some women still want to take their favourite prenatal supplements, which might contain omega-3, but we do suggest that they don't exceed a dose of 250 milligrams per day. So to help educate health professionals about the omega-3 test and treat program, we've developed a number of different tools. We have an information brochure both in hard copy and there's an online copy on our website. And this provides some more background about the previous research done on omega-3 and preterm birth, as well as some guidance on supplementation and where to get some additional information. And we also have consumer-facing brochures that can be given to women when the test is being discussed, so they can make an informed decision about whether they'd like to have the omega-3 test or not. And again, it has similar information, but in more lay language, similar to the health professional brochure, with supplement guidance and a bit of an outline of why we're doing what we're doing. And where to get some additional information should they require it. Other resources we have hard copy health professional information packs, which is just a big A4 envelope which contains all of the different pieces of information that we have, including more information about supplements, how to upload the practice software so you can use a SAMHSRI form, and an updated copy of the hard copy form there. And in addition, we have our own special place on the SAHMRI website for the Omega-3 Test and Treat program, where all of our resources are housed. We do have a dedicated mobile telephone number for people who have any queries about the Omega-3 tests, and we also have a dedicated email address as well. So how are we going so far? This graph shows our progress since we started the program in 2021. The columns represent the number of Omega-3 tests that are being completed each month. As you can see, the arrow is heading in the right direction and the number of tests are increasing over time, and we're consistently now receiving between 700 and 800 Omega-3 tests per month. So this number of tests received means we're currently reaching around 50% of women with singleton pregnancies in South Australia. However, to effectively see reductions in preterm birth, we estimate that we need to reach, or we hope to reach, around 80% of women. So I think we've done fairly well, but we still have a little way to go with uptake of the test. So that's our current focus, is enhancing uptake of the test both by health professionals and consumers, women. We do know that 90% of all SAMHSRI tests are ordered by GPs in South Australia, and at the moment around 45% of GPs are ticking the Omega-3 box. So a lot of our efforts have sort of been focused in primary care sector. We attend the obstetric shared care educational meetings to present on the program. We send gentle reminders to GPs who may have ordered a SAMHSRI test without including the Omega-3, just to let them know that it exists, and to remind them to tick the box if they would like to order it for their patients. And that work is ongoing. We also offer outreach visits to GP practices and to hospitals, but everyone is very busy, and we don't often get taken up on a lot of those, which is understandable. So our consumer-facing strategies to try and increase awareness of the program include a statewide mass media marketing campaign, which included TV, both metro and regional radio ads, as well as social media and print media. And so far we've reached over 500,000 South Australians with this method. This is it's very short from our TV campaigns. So you may have seen that come across your TV, short and sweet, because that's how our attention span goes these days. But that did have good results for us in terms of uptake. It's stalled at the moment because it's quite costly, so we may restart that again as well. In addition to the other consumer brochures and strategies we have, we've also developed some culturally appropriate educational materials for Aboriginal families, and we have given some workshops and education sessions to Aboriginal healthcare workers and Aboriginal services. As I mentioned on the first or second slide, we do know Aboriginal women are more at risk of preterm birth, so it's important that we make sure that we can include these women in the program as well. We also do provide an option for free Omega-3 supplements for Aboriginal women if the Aboriginal Health Service would like that. So In summary, we have successfully integrated omega-3 testing and reporting into the antenatal care system. To date, more than 18,000 women have taken the omega-3 test since its launch in 2021. So it's probably why we're all feeling a little bit tired. Interestingly, around 17% of women have returned a low omega-3 status, and these are the women who may benefit from omega-3 supplementation to reduce their risk of preterm birth. And these numbers are actually very similar to what we saw in the ORIC trial in terms of the number of women who were low. So we're all looking forward to 2026, where we get to analyse the rate of preterm birth in SA before and after the omega-3 test and treat program, but we've still got a lot of work to do to try and not only increase the uptake of the program, but also maintain that until we can finish the analysis. So if you see women who are pregnant, we would really love you to talk to them about the omega-3 test and treat program before their 20 weeks of gestation. And that's about all for me. So thank you for your time. There's the details to get more information. And yeah, we'd love to hear from anyone who would like to hear more. Thanks. I'll stop sharing.
Well, thanks, Karen. That was fascinating. I've got a couple of questions while other people think of their questions.
Yep.
Firstly, I just quickly, while you were talking, looked up all the fish oil supplements and looked up your webpage, and I can see that there are a couple of supplements that have the similar dose of DHA and EPA.
Yeah.
Congratulations, by the way, on your pronunciation of the chemical names. You've obviously done that a few times before.
A few times, yeah.
But how important do you think that ratio is? If you look at most fish oils, they actually have the ratio the other way. The EPA is actually the higher one, and the DHA is the lower one. How did you find out that ratio is the right ratio?
Yeah, well, in our field of work, a lot of the work that's been done in omega-3 fatty acids in our group and led by Professor Maria Macreades, even before we started these pregnancy trials, the work was focused around looking at DHA in pregnancy, because that is what impacts neurodevelopment of children. It's the DHA that accumulates in the brain. So our focus was always DHA more so than EPA. You're right, and that's where this has evolved, because we started off before the ORIC trial, we had the Domino trial, which had 2,500 women, and that was investigating both postnatal depression and neurodevelopmental outcomes in children. We had the same dose of omega-3 as we did in the ORIC trial, the 800 milligrams of DHA and 100 milligrams of EPA, and that's where we first saw reductions in early preterm birth. But there were secondary outcomes and we weren't powered to see those. So that's where we went on to ORIC. So that's how the DHA has evolved. A lot of the supplements with the higher EPA seem to be targeted more towards different conditions, like different inflammatory conditions, arthritis and things like that. Whereas those targeted to women to make their baby smarter, I'm not saying that they do by any means, but they will have the DHA as the primary component because of the brain development.
Yeah, it's fascinating. You'll certainly get a lot of people reading the labels.
Absolutely, and it must be so confusing for people. I mean, it's early days. I'm sure that if this program proves effective, there'll be a number of supplements with exactly the right amount that are targeted, to women for this cause. Yeah.
Yeah. The other question I have is, if you look at fish oil or omega-3 fatty acids in general, the research for things like arthritis, for heart disease, for a lot of inflammatory conditions is generally positive, but not in every patient.
Yeah.
So there's an average effect size. It's not great, but it's there. To what extent do you think that might be related to what you found, that if the underlying levels are normal or high, then there may be a Goldilocks point for all those other conditions as well?
Absolutely. And I think it's the same with a number of nutritional interventions. If you don't know the baseline you're starting from and then you're trying to supplement on top, then you just have this plethora of, soup where you don't know what you're starting with. So I think it's really critical that for nutritional information there is that baseline, so you can actually delve in and see why. Because that's why our results were null with ORIP, and even in the observational studies where they've looked at women who eat fish or don't eat fish, it's and then supplemented based on that, it was the women who didn't eat fish that had the most effect. So yeah, it's plausible that it depends on what your baseline status is, whether there's been an effect.
Then, of course, the dilemma in nutritional science research is, where do you measure that baseline? Is it inside the cell? Is it in the serum? Is it in?
Yes, exactly. Yeah.
That's right. We've got a couple of other questions. Janaea, first.
Hello, thanks, Karen, for your talk. I just was curious about the sort of adverse or maybe unexpected result of having poorer outcomes for women that already had a high level of omega-3. I'm curious what that actual impact was and whether there were any other issues that you found in that population.
No, there weren't any other issues that we found in that population. It wasn't the women who were at the higher end of sufficient. We didn't see any other adverse effects in terms of, things that you might think omega-3 could cause, like postpartum hemorrhage or anything. There was no difference between the groups in any other adverse events in those groups. So, it was unexpected, and I think it's because in high-income countries like Australia, and because of the population that we included, with many of them already being replete at the start, there's not a lot of other studies have seen the same effect that we did. So we are looking more into that now with a new trial, looking at more so with the moderate group to find out, well, what is the best dose for women outside of just the low group, because we need to look after, make sure that everyone's getting the right dose.
Yeah, excellent. Thank you.
And Amy.
Hi, thank you for your presentation. That was really good. My question is more the mechanistic and characteristics of the population that present with low DHA. Because it's not just from diet, it's synthesized in the liver, which is altered with obesity. Like, is there a specific characteristic in this cohort that you can, so that then you can target?
Yeah, we have done a bit of work in that, trying to look at that specifically, and we didn't really find anything specific. Obviously, there are different groups who tend to test low, like lower socioeconomic groups are tending to test lower, and that could be through diet and not as much fish, high rates of smoking, and other nutritional factors. But there's also genetic factors too, which needs a lot more research. In the ADORE trial in the US, they found that their Black population were much lower, than the rest of the population. So it would be ideal if you could have a nice wrapped in a bow list of characteristics that you could target, so then you wouldn't have to do this whole, testing the whole state. But yeah, there's just nothing that directly does that.
Yeah, because we found very similar in the Black South African population. And the DHA synthesis is quite low, similar to the African American. Yeah, so it'd be quite interesting with the low presentation in the Aboriginal population, if there's a similar genetic characteristic there?
Yeah, well, from what we're seeing already, that women are double the risk of testing low. I mean, they've got a high risk of preterm birth, but they're also twice as likely to test low than non-Aboriginal women. So we are seeing that. So that's why it's really important that we've got these other initiatives to try and make sure that they're included in the program.
That's cool. Thank you.
No worries, thanks.
And of course, recognising that particularly on Ngarrindjeri country, Aboriginal women would have had a diet that was absolute threes with their natural fish, shellfish, and mammal contributions to the diet. And of course, that's changed in a couple of generations.
Absolutely.
Through the influence of European Australians. Thank you, Karen, for really stimulating our thoughts and for doing this work on behalf of all the women in our state, and of course informing what we do for women who are pregnant all around the world. Congratulations, and we too look forward to 2026 and finding out the impact. So thank you everybody for your participation today. These grand rounds are put onto our YouTube channel so that you can access them there and you can let your colleagues know about them. And thanks for being part of the Academy. Nakan, and we'll see you again next month.
Thanks, Paul. Thanks, everyone.